Welcome to the program, Navigating the Therapeutic Advances for Spinal Muscular Atrophy. My name is Eric Cannon, AVP of Pharmacy Benefits with Select Health and Intermountain Healthcare in Salt Lake City, Utah. And I'm joined today by Dr. Basil Darras, Chief of Clinical Neurology and Professor of Neurology at Harvard Medical School in Boston, Massachusetts. Today's program information approved for 1-CME, CNE, APA. You can download a PDF of the presentation under the Event Resources tab on the left side of your screen under the headshot. You will be redirected back to the landing page after the webcast to complete the post-test and evaluation. You can then download or print your certificate. The program is provided by North American Center for Continuing Medical Education, LLC, an HMP company. And this program is supported by an educational grant from Biogen. Looking at the learning objectives, today we're going to talk about recognizing the clinical, economic, and psychosocial burdens that result from SMA. We want to apply recent findings on the pathophysiology of SMA to analyze new and emerging therapies with regard to their mechanisms of action, indications, efficacy, and cost-effectiveness. We'd also like to develop system-wide strategies to improve the recognition and treatment of SMA, including patient and provider targeted education of recent therapeutic developments. With that, let me jump into a real broad overview of spinal muscular atrophy. This is the most common genetic cause of early infant death. And if you look at it, the incidence, it is fairly rare. The incidence is 1 in about 11,000 live births. It's caused by a mutation of the SMN2 gene. And as we look at spinal muscular atrophy, basically we have 5 types, which are based on age of onset and clinical course. And I'm not going to go into those right now. Dr. Darras has a few slides where he'll review those different 5 types. If we quickly just look at the mortality, though, this can be a devastating genetic disorder. 68% mortality within 2 years of birth and 82% mortality by 4 years of age, which is fairly significant. One of the things that if you talk to parents, and as a parent I can fully understand this, there are delays in diagnosis. First off, if you think about that first child, you may have had lack of awareness about what those developmental milestones are. And so a lot of times it's hard for parents to really understand or maybe distinguish normal from abnormal development. And then even once they get in to see a pediatrician, there's a challenge of a differential diagnosis. SMA Newborn Screening, Health Resources and Services Administration, or HRSA, in 2018 recommended adding SMA to the recommended uniform screening panel. So those set of tests that we regularly do on each newborn infant. Most of the states have said it's going to take them 1 to 3 years to implement this SMA newborn screening. It is currently in place in 4 states, Massachusetts, Utah, Minnesota, and Missouri. And if you look at some of the benefits that HRSA's put out there, identify 364 babies with SMA each year. But I think as you start looking at some of the benefits here, prevent between 16 and 100 children with SMA type 1 from needing a ventilator each year, and then prevent between 14 and 68 deaths due to SMA type 1 each year. There's a significant psychosocial impact that comes with SMA. If you look at this slide, this is the output of some focus groups that were done with 96 participants, so people with SMA or the parents of infants with SMA. And you look at some of the impacts. You've got difficult treatment choices. You've got significant impact on the family finances. You've got loss of independence. You can see on this also limitations on social activities, loss of functional ability. The parents going through this experience the whole range of emotions and issues, and one of the things that parents have kind of pointed to as being the hardest thing for them is the lack of sensitivity that sometimes exists within our healthcare system. So I think it's a good reminder for all of us to recognize, maybe beyond some disease states out there, there is a significant psychosocial impact on the families. Let's look quickly at the healthcare costs of patients with SMA1. And in this study, they looked at patients that had SMA1 but that were not treated with nusinersen, and then they also looked at patients that were treated with nusinersen. The costs that I'm showing on the screen are excluding drugs. So for those people that were not treated, their regular healthcare costs annually were about $137,000. You can see the breakdown there between, and that's mainly inpatient costs. Those that received nusinersen, their total healthcare costs were $92,000. Now we'll get in and talk about the cost of the drug towards the end of the presentation, but you see more of an even distribution about the sites of service in that nusinersen population. Same two populations here, but looking at how their visits break out in numbers. And so on average, an SMA1 patient had 4.6 visits or inpatient stays. Compare that with the nusinersen, where I think some patients are being admitted to administer the drug. They had 14.1 stays within the hospital, fewer outpatient visits, and then fairly close on the other visits. If we look at the resource utilization, this is a study that was done comparing infants with SMA1 to infants that had complex chronic conditions. So those would be things like epilepsy, muscular dystrophies, cerebral palsy, some kind of cardiovascular malformation. All of those types of things were lumped into this complex chronic condition. So not mild disorders, fairly significant diseases. You can see the SMA cost annually at $150,000 compared to these complex chronic conditions at $112,000. But even in the perfectly healthy, no complex kind of chronic condition, down close to $20,000. Again, SMA length of stay, 4.4-fold increase in length of stay, and actually a 4.2 annually increase in hospitalizations. With that, I'm going to turn the program now over to Dr. Darras for his portion of the program.
Thank you, Dr. Cannon. We're going to talk about spinal muscular atrophy today, but you need to know that SMA is a generic term because it includes, in addition to the chromosome 5q classic SMA, it also includes the non-chromosome 5q SMAs. 5q classic SMA is a genetic disorder characterized by degeneration and loss of motor neurons in the anterior horns of the spinal cord and brainstem, leading to muscular atrophy and weakness. It is one of the most common neuromuscular conditions in infants and children, and it is the most common fatal genetic disease in infants, with an incidence which is about 1 in 10,000 live births. There's a number of studies that gave us different incidences in different parts of the world, but the accepted number this time is 1 in 10,000, which means that given that we have approximately 4 million births in the United States per year, we're talking about 400 to 700 SMA births every year in the United States. In our state, Massachusetts, we have approximately 75,000 births per year, which translates into 6 to 7 SMA births per year. It is important to remember that the vast majority of the babies who are born will develop SMA type 1, approximately 60% if they have the mutation. Approximately 27% will develop SMA type 2, and about 15% SMA type 3. The adult form of SMA, known as type 4, is less than 1%. Again, going back to the incidence of births in the United States, we're talking about between 200 and 350 new SMA type 1 births per year. As far as the SMA carrier frequency is concerned, it is approximately 1 in 54, like 1 in 50, which is only second to cystic fibrosis. It seems to be more common in Caucasians, and it's less common in African Americans, again with an average of about 1 over 50, which translates into about 6 million carriers in the USA alone. SMA was described back in 1891 by an Austrian physician by the name Guido Werdnig, who published a paper in 1891, but also was Dr. Hoffmann, who was a German physician who published on the same disease in 1893, and this is why we use the term Werdnig-Hoffmann disease. But the classification of SMA was developed gradually over a number of years, starting back in 1961 by two physicians at Boston Children's Hospital, Randy Byers and Betty Bunker, who published a classic paper on infantile muscular atrophy, which described primarily type 1 and also a milder version of SMA known as type 2. It was in 1991, 100 years after the original description of SMA by Werdnig-Hoffmann, when the classification of SMA into three main types, type 1, type 2, and type 3, was established. Type 1 is the most severe form, with onset during the first 6 months of life and limited lifespan, given that before they develop treatment, the babies used to die, most of them before the age of 2 years. Then we have SMA type 2, with onset between 6 and 18 months, with approximately 70% of these children being alive 25 years of age. And then we have SMA type 3, with onset either before or after the age of 3 years, who are able to walk and they have almost normal lifespan. And then there are two other types known as SMA type 0, with prenatal onset and symptoms at birth, and most of these babies die shortly after birth within the first few months of life. And then type 4 is the adult form of SMA, with onset after the age of 21 years, normal lifespan. The classification of SMA, however, is based on the best motor performance, and to a lesser extent on the age at onset of the disease, with understanding that we're dealing with continuum of severity across a phenotypic spectrum. Going back to the types of SMA, we talked about SMA type 1, the most severe variety, known as Werdnig-Hoffmann disease. Those are also known as non-sitters because they never sit unsupported. As I said, they die before the 2 years without aggressive treatment. Then type 2 is the intermediate form of SMA, also known as sitters, because these are the children who never stand or walk but can sit at some time. And as I said earlier, their survival is better than type 1, with approximately 98% of them being alive at age 5 years and about 70% living up to the age of 25 years and beyond. And then we have SMA type 3, which is the mild version of SMA. These patients are known as walkers because they're able to stand and walk at some time in their lives. And we talk about the subclassification in 2, 3A, and 3B, depending on whether the onset is before or after the age of 3 years. Coming back to SMA type 1, these are the babies who present with low muscle tone, hypotonia. They have frog leg position of their lower extremities because of the weakness and hypotonia. The weakness tends to be proximal more than distal, the legs more than arms. However, there is some facial sparing in SMA type 1. On physical examination, we find hyporeflexia. Most of the babies have no reflexes and they have tongue fasciculations. But they have no CNS symptomatology. They're not encephalopathic, and but they decline very, very fast without aggressive treatment. So this is images of children with SMA type 1. You can see the very alert face, the frog leg position of the lower extremities. They tend to have paradoxical breathing because of the weakness of intercostal muscles and preservation of diaphragmatic strength. And they have this bell-shaped chest. But again, they do not have any central nervous system symptoms or signs. They're alert. They're not encephalopathic. They smile. They interact with the parents. But nevertheless, they have this severe disease with limited survival before the development of treatments for SMA. SMA type 2 is of intermediate severity. It's also known as Dubowitz disease, with onset before the age of 18 months. Again, these are the children who are able to sit unaided but never walk, but some can stand with support. They can be subclassified type 2A and 2B, as you can see on this slide, depending on whether they lose or maintain the ability to sit, and they have weakness proximal and symmetrical. They can have tongue fasciculations, and they also have this very characteristic tremor of the hands, which creates a baseline artifact on EKG, and it is not of any major clinical significance, but nevertheless is sort of typical of SMA type 2 and in some cases of SMA type 3. These children with type 2 SMA, they have a fairly static course with slow decline over time, and they end up with respiratory failure and scoliosis, which can complicate the clinical course of these children with survival we described earlier. And here is a child on the left with SMA type 2. He is a sitter, and on the right we have two children. One is sitting on her wheelchair. He has SMA type 2. But even the girl who is sitting next to her on the right-hand side, she also has SMA, but she is able to walk, and therefore she has SMA type 3. Again, these are the patients who are able to stand and walk and may show little or no decline over time. They look more like a muscular dystrophy, and they usually have no clinically significant associated respiratory deficit, but some lose the ability to walk over time. Unfortunately, somewhere between 30 and 70% of the children lose the ability to walk, but they do have almost normal lifespan. So for many years we relied on EMGs and muscle biopsies to make the diagnosis of SMA. And this is an interesting slide because it shows the timeline of SMA with the description back in 1891 and the three-type classification 1991. But it was in the early 90s when the gene for SMA was mapped to chromosome 5q, and the SMN genes were discovered by Dr. Melchi's group in Paris in 1995. Now we understand the genetics of SMA very well following the discovery of the SMN gene on chromosome 5. SMN stands for survival motor neuron, and humans have two SMN genes. They have SMN1, which is on the right, on the telomeric side, as we say, and then we have SMN2, which is like a defective version, like a pseudogene, which is on the centromeric side of this region on chromosome 5q, where there's inverted duplication. And this is probably the reason for why humans develop SMA. Humans, they have SMN2, which differs from SMN1 by 5 nucleotides, with one of them being very important. It transition from the C to T in position 840 in exon 7 of the SMN2, which creates an exonic splicing silencer, which modifies the splicing of the SMN2, leading to the exclusion of exon 7 during the vast majority of the splicing events. As a result of that, approximately 90-95% of the protein produced by SMN2 is defective. It is truncated and gets degraded by the cell, but only 5-10% of the protein produced by SMN2 is functional. It is full length, and this is why humans develop SMA. Humans who have SMA, they have what we call a homozygous deletion of SMN1, but they can have 1, 2, 3 or more copies of SMN2, which produce small amounts of full-length protein and therefore allow the fetus to reach the end of the pregnancy. The child is born, but unfortunately at some point will develop with SMA. Other species do not have SMN2, and because the absence of SMN protein is inconsistent with survival of the fetus during the pregnancy, these other species do not actually develop SMA. So 5q proximal SMA is an autosomal recessive condition caused by loss or mutation of the SMN1 gene and retention of the SMN2 gene. We talked about SMN1 and SMN2, which encode the survival of motor neuron protein, and then about the fact that SMA is caused by decreased levels rather than complete loss of the SMN protein, leading to selective dysfunction of motor neurons in the spinal cord and brainstem. Again, total absence of the SMN protein leads to embryonic lethality. We talked about the fact that SMA patients, not 95% of them have a deletion of exon 7 in both copies of this gene. We simply say that 95% have a homozygous deletion of SMN1, and this is what causes SMA. We talked about SMN2 and the fact it produces a small amount, 5-10% of full-length protein. Now, why we have these different types of SMA, the different degrees of severity? That happens because in SMA type 1, 80% have 1 or 2 copies of SMN2. Patients who have SMA type 2, the sitters, 82% have 3 copies of SMN2. And patients who are able to walk have SMA type 3, the walkers, 96% have 3 or 4 copies of SMN2, and rarely they have 5 copies. Patients who are carriers, they have 1 copy of SMN1 and 0 to 3 copies of SMN2. Normal individuals, they can have more than 2 copies of SMN1. Most of them have 2 copies, of course, of SMN1 and 0 to 3 copies of SMN2. But rarely some normal people can have 3 copies of SMN1. And there are also what we describe as normal individuals, at least at the time of ascertainment, who were found to have 0 copies of SMN1 but 5 copies of SMN2. You would expect these individuals to develop SMA because they have no SMN1 copies, but because they have 5 copies of SMN2, it seems that's sufficient to rescue the phenotype and prevent the development of the disease. So we talked about the different number of copies, and what is important to know is that there appears to be an inverse correlation between SMN2 copy number and the severity of the disease, meaning that when a patient has a small number of SMN2 copies, the disease is going to be more severe. And here's the distribution of the SMN2 copies. Let's say in type 1, you see that most patients, we said before, have 2 copies of SMN2, but very few who have only 1 copy, and those are the ones who develop SMA type 0. And then some of them have 3 copies, and this is usually stronger type 1 patients. In SMA type 2 in the center, you see that most patients have 3 copies of SMN2, the blue column, but they can have either 2 or 4 copies of SMN2. And then patients who have SMA type 3, the walkers, they have either 3 or 4 copies of SMN2. It's approximately 50-50. But what's interesting here, you can see that in every type there is a blue column that indicates the 3 copies of SMN2. So if a baby is born and we test the SMN2 copy number and the baby has 3 copies, it will be very hard for us to predict the phenotype, because you can see they can have either SMA type 1 or SMA type 2 or type 3. So it's very hard to predict the presentation because of the overlap between the different types and the fact that you can find, let's say, 2 or 3 copies in every type of SMA, or even 4 copies. So the reason for that is not totally clear, but we suspect that all SMN2 copies are not equal because there are probably mutations that modify the production of full-length protein for SMN2. There might be also phenotypic modifiers that modify the expression of the disease. So 95% of our patients, they have a homozygous deletion of SMN1, but approximately 5% of the time, we send the test and we find that our patient has only 1 copy of SMN1, which means that that patient, in theory, should be just a carrier and not a patient with the disease. In these 5% of the patients, we have what we call compound heterozygosity, which means that what appears to be the normal allele, in fact, is a mutated allele. It's just that the mutation in this particular second allele is a small-scale one, either a missense mutation or a stop mutation, duplication, and so on. So if we have a situation where our patient looks like SMA, but the genetic test comes back as a carrier, we should ask for sequencing of SMN1, looking for a small mutation that would give us the compound heterozygosity, will explain the phenotype. As far as the SMN protein is expressed everywhere, It's a 38 kilodalton protein, which is localized in the cytoplasm and also the nucleus of all cells. It seems to be located in GEMs, which stands for Gemini of coil bodies. And if you take a look at the number of GEMs doing immunohistochemistry, you find that it correlates inversely with clinical severity, but this is not a clinical test by any means. The SMN protein is important for the synthesis of the SMN complex, which in turn is very important for the assembly of the spliceosome. The spliceosome is basically a molecular machine that removes introns from the pre-messenger RNA to create messenger RNA, and after that happens, it seems to leave the spliceosome complex and be deposited properly in GEMs. So the SMN protein plays an important role in small nuclear ribonuclear protein biogenesis, and we talked about the spliceosome assembly, and therefore it's important for pre-messenger RNA splicing. The SMN may play also a role in transcription and other cellular processes, such as axonal mRNA trafficking, transport in motor neurons, and perhaps in other processes in neuromuscular junction and muscle itself. So if you stain a neuron for SMN protein, you find it's not only localized in the cell body of the cell, as you can see on the left, the green stain, but we see green stain also in the axon, and it seems to localize in the axon and the growth cone, and seems to move bidirectionally. But the SMN protein also shares with actin, which is involved in motor axon pathfinding and outgrowth during development. The SMN protein must be very important also for the normal function of the neuromuscular junction. And the evidence from that comes from a number of sources. One of them is morphology. If you take a look at the left, you see normal neuromuscular junctions. They seem to be big. They seem to have this complex type of appearance. Some people will use the term pretzel-like appearance in neuromuscular junctions when they're stained. But on the right, you see in a patient who has SMA, you see that the neuromuscular junctions are small and they're not very well developed. So the morphology seems to be different in patients who have SMA. Also, if you do electrophysiology and you stimulate a motor nerve of a patient with SMA, you may find a decrement the way we find it in myasthenia gravis. And many of our patients complain about fatigue, and that's very common. And this is why the term synaptopathy has been coined by Dr. Monani at Columbia University, indicate that the neuromuscular junction is not normal in SMA. The SMN protein seems to be present in not just in the spinal cord, but also in the brain. You can see here the hippocampus. So it's expressed everywhere. We have ubiquitous expression, but the reason for the selective vulnerability of the spinal cord motor neurons remains unknown. We talked about the SMN2 gene, but the fact that it's an important phenotypic modifier, but it also allowed the creation of animal models for SMA by introducing a number of SMN2 copies into mouse SMN knockouts. As I told you, mice normally and other animals do not develop SMA, but we can engineer an SMA mouse, which is known as SMN delta 7 mouse, which has very severe phenotype with death at 14 to 17 days. In addition to being an important phenotypic modifier, the SMN2 gene has become a therapeutic target using SMN2 splicing modulators and upregulators. So the goal of most drug trials in the field of SMA has been to increase the full-length SMN protein production from the backup SMN2 gene, and more recently there have been successful efforts to replace the SMN1 gene by using gene therapy. So SMA is a unique translational disease, and the reason is that the genetic defect seems to be the same in all patients, and we have clear pharmaceutical targets. The therapeutic strategies for SMA included neuroprotective strategies with medications like gabapentin or riluzole, which have not been very successful. There have been also efforts to amplify the production of SMN protein by using HDAC inhibitors like phenylbutyrate, hydroxyurea, valproic acid, and so on. and a lot of work went into clinical trials, which were not successful for a number of years. In year 2000, NIH targeted SMA as a potential treatable disease. So here's been a number of clinical studies, Boston Children's, the most important one being the natural history study by the PNCR network. We have enrolled a large number of patients, as many as 500, start going back to 2004 and coming to 2019. But our goal was really to develop treatments for SMA with different approaches. Here you can see that many of these trials have failed. When you see an F, means the trial has failed or has been terminated. So it was around 2011, 2012, the main efforts of the PNCR network and also other sites around the world were to increase the inclusion of exon 7 using antisense oligonucleotide technology, or to do gene therapy to replace the SMN1 gene, or use small molecules like RG7916 to modify the splicing of the SMN2 gene. Coming to the antisense oligonucleotide treatment, the effort was to increase the inclusion of exon 7, and a number of researchers at the Cold Spring Harbor Laboratory screened a large number of antisense oligonucleotides, and one of them was found to induce long-term retention of exon 7 after intracerebral ventricular infusion in SMA mice. And initially it was named ASO 1027, and then SMNRX, now it's known as nusinersen. And when it was given intraventricular, I said in mice, it did increase the inclusion of exon 7 by as much as 90%. So the SMNRX is an antisense oligonucleotide has methoxyethyl chemistry. It seemed to correct the splicing disorder in SMN2, resulting in production of fully functional SMN protein in model systems. In mild and severe mouse models, it also provides phenotypic and pathological benefit when delivered centrally, intrathecally, or intraventricularly, and it seems to distribute broadly to spinal cord motor neurons after intrathecal delivery in non-human primates. It seems to have a long half-life in CNS tissue, more than 6 months in animal models. So initially there was a single intrathecal dose study in a number of centers around the United States, Boston Children's, Columbia University, University of Utah, and also University of Texas. And we administered a single dose of 1, 3, 6, and 9 milligrams in a small number of SMA patients, and there were no safety or tolerability issues. However, when the analysis of the motor function results was conducted, it was noted that using the Hammersmith scale, that the patients who received 9 milligrams, the purple line at the bottom of this panel, they seem to have an upward trajectory as far as their change in the Hammersmith score is concerned. And this led to a multi-dose ascending study where patients received a number of doses, different amounts, like 3 milligrams, 6, 9 milligrams. Eventually, we gave a dose as high as 12 milligrams. And this was to assess the safety and tolerability of multiple intrathecal doses, and also to evaluate CSF, plasma PK, and clinical outcomes in patients with either SMA type 2 or type 3, with either 2 or 3 copies of SMN2. So these patients, they receive either 2 or 3 doses over a relatively short period of time, and it appeared as if we're starting to see efficacy. When one of the patients with type 1 SMA who had been treated with nusinersen passed away, and spinal cord analysis was, pathology was performed, it was clear that the antisense oligonucleotide, standing in green here, was entering the cells in the spinal cord, and there was production of the SMN protein. The red stain indicates SMN protein. So this was, in fact, an evidence in a human individual who received, was an infant with SMA type 1, unfortunately passed away, and were able to examine the spinal cord. This led to a study known as ENDEAR, a phase 3 study in SMA infants, which were randomized 2-to-1 to receive either nusinersen or a sham procedure. And this was a global study to assess not only efficacy but also safety and tolerability well. But all patients developed 12 milligrams with 4 induction doses followed by 1 dose every 4 months as maintenance. We used the Hammersmith infant neurological examination to assess these developmental milestones and quantitate the results. And when the interim analysis was performed in the summer of 2016, the results were positive because the percentage of patients who achieved a motor milestone response, which means they were able to acquire milestones, was 41% in the nusinersen group versus 0% in the sham control group. Clearly a positive result. In fact, at the end of the study, the percent of milestone responders was 51%. When we looked at the CHOP intent motor function scores, you can see there was more improvement and less worsening in motor function assessment in the nusinersen treated patients. You can see stained with blue columns, which is remarkable. And this led to the approval of the medication eventually. A publication that described the results of the ENDEAR study appeared in the New England Journal of Medicine in November 2017. There was also a phase 3 study in type 2 patients known as CHERRY study. It was a global study of 120 SMA children with SMA type 2, a 15-month duration, 3 induction 12 milligram doses followed by maintenance once every 6 months. And again, the results were positive, published in another publication in the New England Journal of Medicine. And as I said, the medication was approved in December 2016, and after that he has been administered to patients who have SMA regardless of type and age. There have been also long-term studies for nusinersen in later onset SMA, and what we found was that over 3 years, the nusinersen treatment resulted in motor function improvements and disease activity stabilization, which is not observed in natural history cohorts. These results seem to document the long-term benefit of SMA. As you can see here on the right-hand side, you can see the mean change from baseline over about 3 years of treatment. In the Hammersmith score in type 2 patients, they have the change is plus 10.8 points. In type 2 patients was only 1.8 points in type 3 patients, but this particular scale has a ceiling effect in type 3 patients. This is why the change is not as profound as in type 2. A clinically meaningful change for patients who have SMA when we apply this particular scale is 3 points. In the upper limb module, the improvement was 4 points in SMA type 2. And then in SMA type 3, the 6-minute walk test distance change was plus 92 meters, which is really remarkable given that in most muscular dystrophy studies, the target endpoint is only 30 meters. There were no children who discontinued the treatment due to adverse events, and it seems again that long-term nusinersen treatment improved motor function and stabilized disease activity in these children with later onset SMA. And here is the trajectory that reflects the mean change from baseline in the 6-minute walk test in this large cohort of patients. You can see when they're followed over a 3-year period, we have this upward trajectory indicating improvement over time. Again, this is the average, the mean change from baseline. There are patients who did not improve it as much as shown here, but nevertheless, it appears that over time we have continuous improvement. And then another important effort has been the gene therapy effort to replace the SMN1 gene using Adeno-associated virus, which is a virus different from the Adenovirus that we used back in 1991 to treat a urea cycle defect in a patient by the name Jesse Gelsinger, who unfortunately passed away after the treatment. This virus is smaller and it's it's non-pathogenic as far as we know. It has been tried in many clinical trials with remarkable safety and long-term expression. This particular vector, known now as AVXS-101, is able to deliver across the blood-brain barrier and into the spinal cord, and designed not to integrate into the genome of the patient. It has a hybrid CMV enhancer and a chicken beta-actin promoter with the human SMN1 cDNA in the center of the vector. And on the right-hand side, we have the other elements like the poly-A tail. This particular vector also has these inverted terminal repeats, which increase the speed at which the double-stranded transgene is transcribed and resulting in early production of protein. So the initial experiments were conducted by Dr. Faust and others in Brian Kaspar's laboratory, where they injected delta 7 mice with this particular vector, and they noticed that when the treatment was applied on day 1 of life, the effect was good. On day 5, we had a partial effect. On day 10, there was no effect, probably because of the fact that the SMA mouse is a very severe form of SMA, and it only responds to early treatment. But nevertheless, there was significant transduction of cells in the spinal cord and production of full-length protein. These mice, they seem to be able to move much better than the mice that did not receive the vector, and also they seem to survive longer. You can see the survival curves. Their life expectancy is really excellent compared to the delta 7 mouse that dies within 14 to 17 days. And also they seem to gain weight much better than the untreated animals. It was at Ohio State University when Brian Kaspar and Jerry Mandel, in collaboration with families of SMA, were able to advance a CNS-directed gene therapy to an IND. The initial study, known as START, treated 15 SMA type 1 infants and have encouraging results. Some would say similar or better to nusinersen. And there are ongoing studies like type 1, known as STRIVE, and type 2, known as STRONG, that are ongoing at our hospital and other sites in the U.S. and more recently in Europe. And the results have been very, very positive in the sense that infants who received the higher dose in cohort 2, they seem to acquire motor functions reflected in the Choppington scores. You can see that the trajectories are almost all of them are upward, exceeding that, crossing the 40-point line, which is the limit of what babies with SMA type 1 can do. So these results, in conjunction with the fact that many of these infants acquired milestones, like, for example, 11 of 12 patient cohort were able to sit unassisted for at least 5 seconds. And also they achieved head control. 9 could roll over. 2 were able to crawl, pull to stand independently, and walk independently. So these are remarkable results compared to the natural history of SMA type 1. This led to the approval of a gene therapy known as onasemnogene bepirovirvac, commercially known as Zolgensma, on May 24, 2019. However, there was a serious liver injury warning. It was included in the label by FDA because some of these patients were treated with onasemnogene. They may develop liver injury with elevation of the liver enzymes. So if it's pre-existing liver impairment, we should not treat for gene therapy, and we need to monitor liver function periodically after the gene therapy has been administered for at least 3 months. And this is the reason why we pre-treated with steroids before the infusion, and then we continue for approximately 2 to 3 months. The indication and uses was for pediatric patients less than 2 years of age with SMA who have biallelic mutation in survival motor neuron 1 gene. There's also possibility of thrombocytopenia, so this is why we monitor cell counts weekly, and also elevated troponin I elevations have been noted in some of the patients participated in the clinical trials, and for that reason, only we check troponin I levels, but we also perform EKG and echocardiogram. Cardiomyopathy, however, has not been reported thus far. It was just a preclinical finding, and this is why we monitor heart function. Before we do the infusion, we have to check AV9 titers. It has to be less than 1/50 for us to initiate the treatment, because the titer is high. That's going to neutralize the vector and therefore prevent the positive effect of the treatment. There is also an effort using oral SMN splicing modifiers, and one of them was produced by PTC-Roche back in 2012-2013 with a small molecule to treat SMA by altering SMN splicing. It did seem to extend the life of the SMA mice from 17 days to more than 150 days. A single dose study was conducted in Europe on adult healthy volunteers, but the study was placed on hold because of retinal toxicity. A second SMN2 splice modifier, known as RG7916, is under investigation. Various studies in SMA type 1s, type 1 known as FARFIS, and type 2A3 known as SUNFIS and JULFIS, which are in progress in the US, Europe, and elsewhere. The advantage of this particular intervention is that we have oral administration, and therefore we have systemic distribution. So, after 128 years of following the description of SMA back in 1891, and now we have 2 approved treatments, but can SMA be prevented? It could be prevented if we treat early and pre-symptomatically, because once we lose those cells in the anterior horns of the spinal cord, cannot actually have any significant effect. There have been a number of studies. There has been a nusinersen pre-symptomatic study for patients with 2 or 3 copies of SMN2. As you can see, the red line at the bottom shows there is also the ENDEAR study. This is the HINE motor milestone score. And you can see we have that upward trajectory with improvement in these infants. But when we treat these infants before they have any symptoms, you can see that you can see the blue and green lines representing the infants who have either 2 or 3 copies of SMN2. You can see that the motor milestone score improvement is really more dramatic compared to the ENDEAR study, for example. So these patients, they seem to progress almost normally, particularly the ones we have 3 copies of SMN2. And we do feel that gene therapy should also work in pre-symptomatic infants. So at this point, I would like to turn it back to Dr. Cannon. Thank you so much for your attention.
All right. Thank you, Dr. Darras. It's now my opportunity to talk about system-level approaches that we can use to improve outcomes in SMA. And I think this was a real learning for us. At the point in time that nusinersen was launched into the marketplace, it was an opportunity within our system for us to learn from each other and actually collaborate as a community. When we talk about the management considerations, and I think one of the things that we've always tried to take into account are the clinical types of things. So how well does the drug work? The safety of that drug. Couple that with what are the issues for the patient. So are we going to have an administrative burden? I think if you look at nusinersen and even on a sensmagene, you've got some administrative things that need to happen there. You definitely, in the case of nusinersen, want to guarantee that you're going to have an adherent patient. Couple that with the treatment costs and then making sure that the utilization in the patients that you're treating are appropriate. I think one of the things that's important for us as systems, as managed care organizations, as integrated care groups, we need to look at some of the opportunities that exist. And so, we need to be engaging each other as stakeholders. We want to be working with our partners, both in industry and in healthcare, to increase the number of comparative studies. We want to improve that conduct of evidence synthesis so that at the point in time we go to make a decision, we're ready for that. If you look at some of our challenges we're faced with today, there is this rapid pace of innovation. And we end up with variable definitions and different evidence thresholds. I think clearly, as we've looked at some of the SMA trials, very small populations, and especially in the pharmaceutical world, sometimes we're not used to seeing trials that small. So what are some of the lessons that I think we learned as a system? Expect delays. When nusinersen was released into the market, we really hadn't thought through how we were going to handle that. We hadn't worked through how we were going to provide education and how we were going to coordinate and collaborate care. One of the things that really helped us, and once we put this in place, was really the establishment, and we call it a neurology subcommittee, but it's a multidisciplinary team made up with specialists from the university and our children's hospital. I think there's an ethicist that sits on there, pharmacist. But that multidisciplinary committee really taking a step back and really talking about what does the evidence say and where is it appropriate for us to be treating and who should we treat. That only works if you have an engaged senior leadership and really engagement with your clinical specialists. So if the neurologists within your system aren't bought into the process of this collaboration, it's very hard to pull these groups together. The whole idea of this is that we want to continue and improve upon what we already consider to be a very patient-focused system. And so everything done with that patient in mind. Quickly Here's a checklist that was actually published in the Journal of Managed Care and Specialty Pharmacy Journal. And I thought it had some great bullet points. I'm not going to take time to go through all of them, but, organize a team of clinical and operational experts. What are those efficiencies that we want to identify in the administration of the medication? And really kind of commit organizational leadership so that once a decision's made or once a pathway or protocol is identified, we know we have the commitment of the leadership within our organization that we're going to follow through with this. So on this slide, I've kind of spelled out maybe the membership that could exist within that multidisciplinary team. I've left nursing off of this on accident. It wasn't intentional. But, really patient representative, physician leaders, clinical specialists, and then even what we found was it was really important as we started talking about very expensive drugs that we needed to have finance in the room so they understood what was going to happen. And I think this really allows for us to have a shared decision-making type of system and really engage the stakeholders. So if we look at the treatment options, we've got nusinersen, about $750,000 the first year, and then on Asensmagene, about $2.125 million, single administration only for use in patients under the age of 2. But I think I throw the costs out there because I think as we look at some of the cost effectiveness data in the next couple slides, I think it's important to understand where is list price on these medications. So in one of the studies I showed you early on in the presentation, we looked at the total healthcare costs, and it was comparing two cohorts, those that had SMA1, and then a second cohort, smaller cohort, those that had SMA1, and were treated with nusinersen. You can see that in that trial for those 45 patients, what they've done is they've broken down the mean costs here per patient per month. And so for the first 3 months, months 1 to 3, the cost was over $190,000 per month times those 3 months. And then for months 4 through 12, what they found in the study was that the costs were about $37,000 per patient per month. If you look at that in total, in aggregate, we're looking at almost $1 million in treatment just for the cost of the drug broken out for this patient across 1 year based on the data that came out of this trial. And I think, again, we're looking at real-world evidence that doesn't have all of the controls of a clinical trial, but I think it does give us a good picture into what the annual costs are per patient. So in 2019, early in the year, the Institute for Clinical and Economic Review, or ICER, did publish a review of the treatments for SMA, and then later, about the 24th of May, they released another update to that cost-effectiveness work that they had done. You can see for nusinersen, they used the cost list price for the second year of treatment, and you can see the population that they put into their studies. What they were looking at is what should the annual price be to achieve a quality adjusted life year. And so they've put that threshold between $100,000 and $150,000 for every quality adjusted life year gained. To hit that, nusinersen would have to have an annual cost somewhere between $36,000 and $64,000. On Asensmagene, you can see kind of where that breaks down, $310,000 to almost $900,000. Now, they also looked at what's the cost per life year gained. And again, they put that threshold in order to achieve $100,000 to $150,000. On Asensmagene comes in a little bit closer to where this pricing came out. ICER put the annual price somewhere between $710,000 and $1.5 million. In the case of nusinersen, upwards to $72,000 a year. Their final conclusion, based on the current pricing, was that the existing treatments would need to be discounted significantly, almost up to 80%, to be cost-effective based on the thresholds that they established in doing this work. So in conclusion, SMA is a devastating genetic disorder. We've got new treatments, and they're showing positive results. I think one of the things that I make sure that I'm always talking about with our leadership is these are kids that most likely would be dead. by 18 months if we weren't having access to these great new treatments. Neither one of the currently available treatments are going to meet the ICER thresholds for cost effectiveness. Care for our patients is greatly enhanced when we work in coordination with multidisciplinary teams, and I think what we've found is patients are more satisfied. Some of those psychosocial issues that we went over at the beginning of the presentation, they're not having to deal with when we can get things into multidisciplinary teams. And then many of the models recently used to review new treatments for SMA, these same multidisciplinary teams and models can be applied in other disease settings. And so I think as we continue to see new orphan drugs come onto the market, we do have a model that can be extrapolated and put in place for other disease states. With that, that concludes my presentation. We will now move to the question and answer section of today's program.
Dr. Darras, we've had a question come in, and it's really asking about the copy number of the SMN2 and the phenotype. Can that predict clinical severity?
Well, the SMN2 copy number is a pretty good phenotypic predictor, but it's not a perfect one. And the reason for that is that not all copies of SMN2 are the same. So we say that most patients we have SMA type 1, they have 2 copies of SMN2, but there are patients who have SMA type 3 who have only 2 copies of SMN2, and so on. So there are copies that make a lot of full-length SMN protein, and others that do not. So we do have some overlap between the different distribution of the SMN2 copy numbers, and that's why in the clinic it's very hard for us to predict the phenotype based on the SMN2 copy number.
Great, thank you. We've had 2 questions kind of come in around SMA screening. One asking if we've seen any benefit in the population, and for us in my area, we have found a few children. I think we found them earlier than we would have and been able to start treatment. Clinical justification for that. I mean, Dr. Darras, are you seeing clinical justification for doing the screening?
Absolutely. Now that we have 2 approved treatments for SMA, and given that all the evidence points to the idea that you need to treat as early as possible, the newborn screening programs have become very, very important, because if you make the diagnosis shortly after the baby is born and you intervene in the first month of life using either gene therapy or nusinersen, you may be able to prevent the disease. We're still learning about this, but from the nurture study of nusinersen, it seems that the vast majority of the patients who have been treated during the first 6 weeks of life, they seem to progress almost normally as far as motor function is concerned. We don't have similar information about gene therapy because the experience is limited. So it's only about a year or so, but I feel that we'll probably have similar results if we use gene therapy. So the earlier you treat, the better it is, and therefore it is very important to be able to add SMA to newborn screening programs throughout the country and throughout the world to be able to make the diagnosis as early as possible and intervene within the first few weeks of life.
So one of our, Dr. Darras, one of our listeners on the program is asking, do you believe now that we're going to be doing more newborn screening, so it's happening in Massachusetts, Missouri, Minnesota, and I think Utah, do you believe that the estimates are underestimated and that when we start doing newborn screening, we'll actually find more cases than maybe we had anticipated?
Well, it is possible, although the estimates we have in fact, may be a little bit overestimated. And the reason is that since the American College of Obstetrics and Gynecology decided to recommend preconception carrier screening, many couples get screened before they have before having a child, and they can take measures to avoid the birth of a child who has SMA. So it is possible that, in fact, the numbers may go down a little bit. For example, in a state where you expect 5-7 births, SMA births per year, you may end up seeing 3, 4, 5 or something. As far as having higher numbers, it depends, I think, on the country and the state and all that, but I doubt it.
Okay, great. Well, that is all the time we have today for questions. We appreciate everyone joining you, and just say thank you for your time and goodbye.